Welcome to my Instagram Live. I am going to be talking here pretty shortly to Dr. Tiffany Troso Sandoval, and we're going to be talking about all things HRT and breast cancer. So as people are jumping on, I'll just be hanging out here with my dog, who will probably bark a lot during this. But anyway, we're going to talk about breast cancer and HRT, the relationship between estrogen, progesterone, testosterone, and breast cancer, what we know, what we don't know. And then, of course, the relationship between taking these hormones and how that affects your breast cancer risk in the future. And then also, if you've had breast cancer, what do we know about your risk of taking these hormones? And most importantly, what do we not know? Because that's probably a bigger bucket than the no bucket. But anyway, so that's the plan. So I'm sort of new to doing these, so I'll have to make sure that I am checking on to see when Tiffany Troso Sandoval has joined us. Dr. Tiffany Troso Sandoval is my guest here today in a few minutes. Hello to everyone who's joining. Hello, hello. Thank you so much for coming on. I'm sitting here with for some reason, my daughters have decided to they're 16. They have all these very large stuffed animals, and they've decided to bring them all up and to have them in my living room. Anyway, so those of you who are new, just so you know, we're going to be talking about HRT and breast cancer today. So hopefully some of your questions will be answered. I suspect you'll have continued questions because unfortunately we don't have all the answers about this subject, but what is the relationship between estrogen therapy and breast cancer? What about progesterone? What about progestins, the synthetic progesterone? What about testosterone? There's actually some interesting research. I don't know if you've seen it. Let's see if Dr. Glazer's on here yet. There's some interesting research over the last 5 or 10 years by Rebecca Glaser, who is a breast surgeon, and she's done some research on testosterone, and there she is. Anyway, and how testosterone in some cases is anti-proliferative and anti-breast cancer in some patients. So that's something that's interesting as well. All right. So Dr. Troso Sandoval, if you're on, which I see you are, just ask me to join, or maybe I can ask you to join so that I can have you jump on here with me. Bear with me, guys. I'm not so good at these, but I'm gonna make it work. Okay, yeah, so just ask me to join and then I'll say yes, and then you can come on here with me. One of the toughest patients that I have is people who have high concern for breast cancer, whether they have a family history or they have a BRCA mutation, or of course the toughest are women who've had a history of breast cancer themselves at some point in the past or distant past, and them wanting to know, like, what are my options in terms of HRT is always a little bit of a struggle, especially since almost invariably their oncologist says no hormones. And so we have to always figure out, like, what do we do about that? We don't want to step on anyone's toes. We don't want to be unsafe. Yeah, Dr. Tiffany Troso, I have invited you, so you should just be able to accept my invitation. There we go. Go live. Oh, there we go. She's coming. I did it. Technology is going to work, I think. I accepted you. Oh, it says you're unable to join. Hold on. Let's try again. Go live. Thank you to all who are waiting patiently. You're such good people. I don't know why it's not. It says I keep asking you, and then,
there we go.
There you are.
There we go.
Goodness. Why is it always so difficult? Why is technology so hard?
Isn't that crazy?
It's so crazy. Well, thank you so much for coming. And I was saying your name wrong. I was saying Torso, but it's Troso.
It is.
Troso.
It's Troso. And I usually only go by my first last name because I got married. And anyway,
Okay.
so I'm Dr. Troso.
Troso. Perfect. Well, I said thank you for being here. I would love to start if you can just give us like a little introduction to who you are, what you've done, where you are now. That would be an awesome way for us to kick this off.
Absolutely. And I have to tell you, thank you so much for having me here to do this. I think it's such an important topic for everybody to listen to, and I'm honored that you're taking the time to discuss it with me. So I'm a medical oncologist. My name is Dr. Tiffany Troso. I specialize in breast and gynecological cancers. I worked at Memorial Sloan Kettering for 25 years. I retired in August, and this is my new venture. I am seeking to educate and empower women with histories of breast cancer and gynecological cancer. I also help patients that have active cancer as well. And so I think this is such a beautiful time to bring this up, because I know that there's a lot of information out there now about menopause and hormone replacement therapy. And I think the tides are shifting. So I'm really looking forward to this conversation.
I'm so excited. And I think that, I mean, I've had so many people reach out to me with the same questions about, you know, what is the relationship between these hormones and breast cancer? Can I have these hormones? Can I not? Like, how do we know? There's so many women, especially people who've had breast cancer, who feel like they have no options, and doctors won't talk to them because we're all too scared to like deal with them. So I'm so happy that you have kind of switched over into like this realm of medicine and offer people, you know, some options. So if you're not following her, make sure you guys follow Dr. Tiffany Troso. But let's get started with maybe the easier questions in this, and not super easy, but a little easier, on discussing the risk or not risk. Do these hormones, if someone who does not have breast cancer risk, do these hormones, estrogen, progesterone in particular, increase women's risks of getting breast cancer from your experience and your knowledge of the literature?
Sure. So if you don't mind, I just want to back up one step and say, in case everybody here isn't up to date on breast cancer treatment. So in general, we will divide breast cancers into either hormone sensitive, HER2 sensitive, both, or none. So triple negative is not sensitive to any of them. HR positive is sensitive to estrogen and progesterone, and HER2 can be HER2 positive, but also HRPR positive or HRPR negative. Okay, so some cancers are activated by the presence of estrogen. And I think one of the very big debates in my mind is whether or not estrogen causes breast cancer in the first place. And then the next question is whether or not, if you've had breast cancer, if it will make it come back again if you started taking estrogen supplementation. So as a medical oncologist, you know, I think I mentioned this to you the other day when we chatted, that I've spent most of my career putting people into menopause. And not because I like it, but because it's a necessary evil in the treatment of their certain breast cancers. So it's a very hard switch for a medical oncologist to then think about adding estrogen back for some of those patients, because, you know, the analogy would be taking, you know, a fire that's already smoldering and then throwing some more gasoline on top of it, and then it grows. So that's not to say that I think the estrogen caused the breast cancer. I think those are two very different things. And I think that there's a lot of research that still needs to be done in the field of estrogen receptor positive breast cancer, and whether or not hormones in your own body or taken orally can increase that risk of it happening. And then I guess the other thing is that we were talking about that article that came out by Dr. Pamela Munster. And after the show, I will put down the links for some of these articles that we discussed today, about how, if you go back into some of the research, it's actually concerning that perhaps progesterone might be the bad guy and not actually the estrogen. And a lot of the HRT studies that were done in women looking at risk of breast cancer often showed that the risk was substantially higher, not substantially because it's not high to begin with, but is higher if the patient was taking combined therapy, estrogen and progesterone. And so I think that there's a lot more to be looked at in terms of what causes breast cancer. But in general, I think most of the studies, which are unfortunately pretty old, and a lot of them are quite small or were incomplete, does not show a significant rise in the risk of developing breast cancer if you're taking HRT. There is a small risk, and I think everybody that considers taking it has to think about their own personal risk of breast cancer and take that into consideration. I'm talking a lot though, Amy. Why don't you tell me what you think? Because I could talk all day. I could talk all day.
No, I can too. You know, I think that it is Well, first of all, as you know, the randomized controlled trials, most of them, the ones we have where they gave estrogen to one group and not to one group, and they were pretty matched, like the Women's Health Initiative and also 9 other small ones, which all use oral estrogen, and those were all without the progestin, as you mentioned. Those are the ones that, we see that reduction in breast cancer risk, of the 22% overall reduction in risk. I think that your point about progestin is very interesting, because it is that, and I say progestin, not progesterone, because in the studies where we've seen increased breast cancer risk that was tied to that progestin piece, it was one of the synthetic progestin. So it was like medroxyprogesterone acetate, or it was the NETA in the HABIT study. There's only one study where they gave progesterone, and it was over more than 6 years of progesterone. It was associated with a small increased risk in the E3N study, I believe. But every other study with progesterone has not shown increased risk. Progestins have shown increased risk. And so that's another question. Like, is there a difference? Probably. Whether progesterone by itself long-term increases risk, we don't know. Whether estrogen long-term increases risk, we don't really know, because most studies are only getting, they're short studies. They're not going to be like 20-year studies. They're usually less than 5 years. So I think those are good questions. I think short-term, we know that estrogen and a progesterone don't seem to increase risk, at least in the randomized control trials. Long-term, potentially. I just don't think we know that, is where I feel, I sit on that.
No, I agree. And, something else I wanted to point out in some review of the literature is that they've actually done DNA analysis, genomic studies of looking at patients that have particular breast cancer genes, for example, BRCA1 and 2. And when they looked at those particular genes and the interaction with estrogen and the risk of getting breast cancer, it does not seem that those patients are at increased risk. So if you have a BRCA gene, taking HRT does not increase your risk above the baseline that you already had from having the BRCA gene, if that makes sense.
And same with family history, at least from what we know. Family history, although you do have an increased risk of breast cancer, it does not seem that adding HRT to that increases your risk even more than just the family history risk. So I think that, I think we also have to remember that, like you said, it's always a risk benefit. Like we certainly, there might be a slight increased risk of breast cancer, especially with long-term use, but what are you reducing the risk of? And I believe I read somewhere, and you can tell me this, but that even women who get breast cancer, they die more often of cardiovascular disease than of breast cancer. Is that right? I read that somewhere, and it seems crazy, but
I think that I don't know that I can answer that question. I don't know that I know that specific answer, but what I can say is that I agree with you that the benefits of taking HRT in terms of all of the risks of being in menopause, Alzheimer's disease, cardiovascular disease, bone disease, all of the things that we, and as well as all the symptomatic issues that we get from menopause, I think really makes one pause to think about how we can make or allow these patients to take HRT and make it more pliable for even the oncologist to okay it. Because I think that that's a very big barrier. Of course, that, in my training and growing up in oncology, so to speak, hormone replacement therapy was it was not something that we discussed at all. I found in the past few years, especially at Sloan, we became much more lenient with prescribing vaginal estrogen. And, we can talk about that a little bit more. And now there's all these papers are coming out that, on a mass level that, it is safe for all breast cancer patients to take the estrogen. Do you use that a lot primarily, or? Yeah,
and I think that that's one message that's pretty clear at this point. I'm glad you brought it up, is that the low dose vaginal estrogen, the low dose is important. It has to be the localized vaginal estrogen. So it's the kind that's not getting into your entire body, but it's staying in your pelvic floor. That does seem to be safe, even in breast cancer survivors, even, no matter what kind of breast cancer, because we're not significantly influencing the hormonal, we're not changing estrogen levels in the rest of the body. We're just changing it in the pelvic floor. So I think that's awesome. I think that for sure, at the minimum, breast cancer survivors should have access to the low dose vaginal estrogen.
Absolutely. And I had gotten to the space where I was comfortable enough giving that myself. Once it got to be a more complex issue and there were multiple menopausal symptoms that needed to be addressed, I do tend to favor referring to a menopausal specialist, although I'm in the middle of getting my certification right now myself. But you and I will have a lot of work to do together, because there's so many women together that we can help in this situation, because it's such a big question and it's such a black box for so many people that it's amazing that it hasn't been addressed more thoroughly until now.
So let's talk about what's the trickiest question, which is when you have someone who's had breast cancer, and I know there's different types of breast cancer, there's different stages, there's different, I know there's so many different variables, and that certainly you're not giving anyone medical advice, but what are the ways that you think about, who's eligible potentially for HRT, who is a hell no, no way ever, who is maybe in the gray zone, and then how do you make that decision based on kind of where we are right now?
Sure. So great question. And of course, it's not a simple answer. And there, as you mentioned, different types of breast cancer have different risks with the hormone replacement therapy. So off the bat, triple negative breast cancers, which are not ignited by estrogen, are not fed by estrogen, there's really no clinical reason not to give those patients HRT. I can tell you that oftentimes it's still not favored in the oncology office, because they've actually looked at patients that have triple negative breast cancer, and there can sometimes be an increased risk in those studies, but I don't think that they're well conducted, and I don't think that they necessarily show the whole landscape. So I personally was not opposed to HRT and triple negative. Same for HER2 positive patients that were hormone negative. So if you have HER2 positive, ER negative, HRT, I don't see any direct contraindication to.
Okay.
So the third group is the problematic group. That's the hot group to answer. And so a patient that has hormone receptor positive breast cancer, just to review how we treat those. So certain patients will get chemotherapy followed by anti-estrogen therapy. And then there's different levels of anti-estrogen therapy that we use there. I can go into in a minute. But a lot of those patients are put into menopause, not just by the chemotherapy, but oftentimes if their cancer is high enough risk, we give them injections of drugs like Lupron and Zoladex to help put them into menopause, and or take out their ovaries to put them into menopause. So if the cancer is high enough risk and estrogen driven, oftentimes we will impose menopause on these patients to help prevent the cancer from returning and to treat any micrometastatic disease that we don't see. So the question is, basic patient has chemo, has a moderate risk of breast cancer recurrence, and has hormone receptor positive disease, and is in menopause and is miserable. How do we handle this? So first off, I would say if the patient is currently on anti-estrogen therapy, HRT is a no-go, right? Because it's basically, opening the door and pouring the water in at the same time. It doesn't, or the drain and then pouring the water in at the same time. It just doesn't make sense, because you're actively fighting a cancer at this point. There's all kinds of conversations that we could have about, well, how long does the hormone therapy have to go for, the anti-estrogen therapy? How intense does it have to be? But that's for another day. So then the other problem is, so there's a test. There's a couple tests that are available. One's called BCI, Breast Cancer Index, and one is called Mammoprint. And both of those tests can look at how sensitive the cancer is to estrogen. And we utilize those tests in the clinic to see whether or not the patient needs to be on 5 years of anti-estrogen therapy or 10 years. So that's a good barometer there. So let's say for fun that the patient's test says that you don't need to take 10 years. Okay. You get a result that says it's not going to help you to take an extra 5 years of therapy, and they stop it at 5 years. So then can they take HRT? Yeah. Well, and there lies the problem. So the question, I've heard this discussed by other menopause and oncologists that, well, how far away from the hormone therapy can you start it? So say you stop the anti-estrogen therapy in 1990, or 2000, and can you start HRT 5 years later? Can you start it 10 years later, 8 years? Do we know? We don't know. We do not know. And I would say, pretty solidly that medical oncology is not routinely offering HRT to these patients because it is such an unknown. I know that there are some studies that are showing that it could be safe, but there would have to be very, very hardcore, large, convincing evidence for me to put my patient at risk potentially with HRT in that situation, since we did everything under the sun to try and get rid of the cancer. And so it's really a dilemma, because of course, you know, I'm 55. I'm singing with the choir here. And the last thing I want to do is make people suffer with menopause symptoms. But on the other hand, as an oncologist, it's also my job to treat and cure their cancer. And so it's really a problem. We were talking about how I think it's an enormous need to find some other barometer to be able to assess, to see who really could safely take it. And, you know, as a molecular biology major, for instance, so I always go back to the DNA stuff. And so I really feel that it's important to try and figure out a way to measure genetically, DNA wise, in the tumor, how sensitive it is to the hormone therapy, and really, you know, does it matter or not? And so I think that our science right now is so not specific that I don't think anybody can really safely tell somebody statistically what their particular risk is. And I think that that's really what we need, not, you know, not percentages from, you know, clinical trials that are 20 years old. I feel, you know, so I don't know, what are your thoughts?
No, and I think, I mean, obviously, it's hard for me to treat women. And I don't talk about breast cancer. I don't talk about breast cancer survivors on my Instagram a lot. You probably noticed that. And the reason is because I feel like it is so difficult for me, if I get someone who's a breast cancer survivor who comes to me and wants hormones, it's so difficult for me to say, okay, I'll give you hormones, if their oncologist is saying, hell no, you cannot have hormones. Like, it is so hard, because I don't want to hurt this person. And I won't be taking care of them if they get breast cancer again. And yet I also know, you know, you mentioned there are a handful of studies. There's, I think, 15 or 20 smallish studies, but some of them up to 1,000 patients who, you know, that had breast cancer, they got HRT, that there was no increased risk of recurrence. And even in the big study, the HABIT study, which is the big study that came out in 2000, I think it was 2000-ish, 2004, I think.
2004,
That was the one that said, you know, that if you take, essentially the study was stopped after just 2 years, because these are people who had breast cancer, they gave them hormones, and within 2 years they saw, like, I think it was a 3 times or 3.5 times increased risk of breast cancer recurrence. So they stopped the study early, and it was, you know, it's a scary thing. They went back in 2008, so 4 years later, and they looked at the data again, and they said, yes, you know, we were right. Like, these people who got hormones did get more breast cancer. However, there was not, at least in the 4 years, and we don't know long term, but in those 4 years, there was not increased risk of breast cancer mortality or of overall mortality compared to the group that, you know, did not get hormones. But I agree. I think that, you know, if you tests like, potentially the test you mentioned, like the BCI, where you look at the hormone, you look at the tumor, and you can tell, you know, it gives you information about hormone susceptibility. Tests like that are what we need. And I think that because oncologists have spent so much time trying to get rid of estrogen and progesterone, that that this field hasn't maybe even thought about, like, how could we best serve women who want to take hormones, like what testing should we develop, like you mentioned, like what needs to happen, because I feel like we have the tools probably that these things could be discovered. We just haven't put a lot of resources to it, because the oncology is like, no, we don't want to give these women estrogen.
And also because menopause has sort of been like a brushed under the table type of a topic for a long time, but now it's coming and becoming, you know, very prominently discussed in the media and among patients, survivors, previvors. I do want to point out, though, there was a recent, I think it was, 2023, somebody did a systemic review, a meta-analysis, where they took 4 randomized clinical controlled trials, and there's, I don't know, 16,000 patients all together in this, and they actually did show that there is a detrimental prognostic effect for patients with breast cancer survivors taking HRT. So again, is that definitive? No, meta-analysis does not necessarily define our medical practice, but on the other hand, it's very thought-provoking. And I think that the answer, we don't have the answer yet. And so, you know, fortunately or unfortunately, in medicine, you know, the first thing you learn is do no harm. And so I don't want to bring back the breast cancer. And, you know, to your point before, that even if it doesn't cause necessarily mortality in those first 4 years, ask somebody who's had breast cancer and had to have a mastectomy and had to have chemotherapy or had to have X, Y, and Z about whether or not they wanted to take the risk of it coming back again and have to undergo treatment again. You know, there's a big divide there. So
True.
again, I'm not disagreeing at all. I'm just saying that I am not satisfied with the evidence that we have yet to make a definitive statement on it for patients that had HR positive breast cancer, unfortunately.
Yeah.
But how about Veoza? Do you use Veoza?
Not too, I mean, yes, sometimes. I don't use it a whole lot. Honestly, most of the patients that I have, we're mostly just doing kind of bioidentical hormones. And if they oftentimes will have gynecologists or people who are also working with them, or oncologists or other people like that are working with them and using other tools that are out there. One thing I was going to ask you about, which, and maybe you don't know because I know you're just kind of new to getting into this part of it, but what are your thoughts, or do you have any thoughts on testosterone therapy in these women? And I know that, we know that testosterone a little bit gets aromatized into estrogen, but it's not a lot. It's only, I just looked it up today, it's only 0.15% of the testosterone that you give someone in women gets aromatized to estrogen. And certainly if you have more body fat, it's a little bit more. But Dr. Glazer has done some studies on this, and she's a breast surgeon looking at giving testosterone either to people who've had breast cancer or even just women who don't have breast cancer but trying to kind of prevent it in the future. Do you have any thoughts on testosterone specifically in breast cancer?
I have some, yes. So again, in this particular circumstance, again, when we say breast cancer, you have to, again, define which type of breast cancer you're talking about. So for example, we did a lot of studies at Sloan looking at patients that had triple negative breast cancer and what the presence of the androgen receptor is on those. And up to 80% of patients that have triple negative breast cancer.
My dog, sorry, just ignore them.
Okay. So can have androgen receptor positivity, which means that just like.
No, keep going. I'm listening. I'm going to go outside so they don't surround us.
No worries. So that, if you have positive androgen receptor on your breast cancer cells and your androgen is testosterone, and you take a testosterone, I don't know that it's safe in those patients for sure. Yeah. The second case, because in those patients, actually, we've done studies using anti-testosterone therapy to treat triple negative breast cancer that has actually been fairly successful. In patients that have hormone receptor, ER positive breast cancer and giving testosterone. So again, I don't have a strong opinion about this, but just knowing medically about HR positive breast cancer, if you can imagine a woman that's premenopausal, say she has 100% of estrogen, she has 100 milligrams of estrogen in her body, right? And you take that estrogen down to less than 5% of what her previous premenopausal state was, down to 1% or less, then you give an aromatase inhibitor, you're taking her percentage down to almost nothing. And so the question is, does the 0.15% of testosterone that's turned into estrogen, is that enough or not? Yeah. And so, just like what, I'm sorry, one last point. Yeah. Just like with the hormone receptor and the estrogen therapy and the use of testosterone therapy, we're going to find large numbers of patients that can definitely get away with it and that it's okay. The problem is, and my issue is that I can't tell ahead of time who those patients are for sure. And even the ones that have like a stage 1 ER positive breast cancer looks all the world clinically like it's low risk. We know that their risk of recurrence can last 20 years. I've unfortunately had recently a patient of mine that I treated 12 years ago. She got chemo, the hormones, the whole thing. She's in remission. She moved to North Carolina and boom, it's back. And why should it be back? She's in menopause. She was fully treated. She didn't take HRT. Anyway, that's not the point. My point is that the risk of recurrence can go out up to 20 years. And so, the question is, well, when and how much and who, which one of these patients is it safe for?
Yeah, I wish that we had those answers, and I know that you wish as well. We have a couple more minutes left, but is there any other kind of thoughts that you want to give us, words of advice? I would love to do this again, and we can dive more into details. But anything else, like any other sort of last parting words with my audience here and your audience that you want to share with us?
Well, just that I want to thank you again, because I think that the education that you're providing to your audience is outstanding. And that's one of the reasons I reached out to you, because I loved your style and how well thought out your commentary is. And I am honored to be here. The other thing, though, I just want to say, again, as a medical oncologist, I am not drawing the line hard in the sand. I still think that it's absolutely worthy of a discussion with your oncologist and with a menopause specialist for each and every patient out there. I, told you the guidelines of what I think seems safe at this point, but I am one person. I'm an expert, but I am one person. But I do think that across the board in oncology, we need more medical evidence to be really comfortable with the hormone receptor positive breast cancer patient survivors. But to be continued. I'm very open to being proven wrong and to have more research, and please to help me decide who it would be safe for me to give it to. So
yeah. Yes. Well, thank you so much for coming on. Thank you for all of you who joined us. Appreciate you for doing that. And we'll do more of these if you guys want, because I think they're super fun. Yeah. I'm sorry about my dog. My dog's apologizing.
Oh, don't be silly. And just to let everybody know, I know there were a bunch of questions that were scrolling on the bottom. We'll try to get to those in messaging. Okay.
Yeah. Sounds good. All right. Bye, everyone.
Bye. Thank you.